Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome everyone on our second day of the conference, Kuwait Lab Advancement in Clinical Biochemistry. Before we start our fourth session, I'd like to announce to everyone that we will be having a competition at the end of the day where we'll be asking questions about the sessions and there will be valuable prizes. So please stay tuned. Also, you can scan the barcode during the session if you have any questions for the speaker. My colleague, Ms. Shaima, will introduce the first speaker.
Good morning. Our first speaker is going to be Dr. Yadav Girish. He's a senior clinical biochemistry consultant having more than 45 years experience in Kuwait. He has a fellowship from the Royal College of Pathologists of England and further training in the United States. He has witnessed the growth of Kuwait's clinical biochemistry services from mostly manual to today's advanced level. Through his active interest and sincere work, he has established many new patient care biochemistry services, and he's currently working to evaluate and establish diagnostic services for Alzheimer's disease. Let's welcome Dr. Yadav Girish.
Thank you very much for the introduction. After yesterday's very informative and interesting sessions, I will start today's day with my talk regarding Alzheimer's disease, clinical future applications of Alzheimer's disease fluid biomarkers. The world's population is aging. According to the report of United Nations, by the year 2050, 16% of world's population will be over age 65. And by the year 2100, 25%, means 1 in 4, will be over the age of 65. Now, aging is a very complex phenomenon. It involves many functions, many metabolisms, and processes for the cellular senescence. But thanks to the scientific developments, which has improved the lifespan and healthy aging. But at the same time, aging can be pathological as well. And when the pathological aging affects human brain, it can cause dementia. The difference, the normal aging is a slow process, while pathological aging can be a faster process. But from normal stage to dementia stage, there is a big, long period of phase period where there are no clinical symptoms. This shows the prevalence of dementia in the patient with age. Prevalence is increasing with the age, and particularly it is more in women than in men. So the number of people with dementia increases exponentially, and according to the report of WHO 2023, more than 55 million people worldwide were having dementia. Now, a person, when he or she has dementia, they will approach to the healthcare service providers such as general physicians, neurologists, psychiatrists, psychologists, geriatrician, or any other healthcare provider. And the specialist healthcare provider will do all these procedures, starting from signs, symptoms, personal and family history, cognitive testing, mini mental status examination, MMSE, Montreal Cognitive Assessment, MOCA, neuropsychological tests, radiological tests and EEG, brain imaging techniques such as MRI and FTG PET scan, and laboratory tests particularly general and specific laboratory tests, and CSF and blood analysis of biomarkers if available. Now, there are a lot of causes of reversible dementia, such as diabetes, lipid abnormalities, infections, thyroid problem, vitamin B12 deficiency, carbon monoxide exposure, such as fire, certain side effects of certain medications, and can be tumor also. These are the reversible causes, but there are a lot of other causes of irreversible dementia. The common ones are Alzheimer's disease, vascular dementia, Lewy body dementia, frontotemporal dementia, Parkinsonism dementia, and there are many other uncommon causes as well. Out of all the causes of this irreversible dementia, Alzheimer is the commonest. About 50 to 75% of cases of irreversible dementia are due to Alzheimer's. So, this Alzheimer's disease was first described in 1906 after the general physician, Dr. Alois Alzheimer, described it as a peculiar disease. It affects more than 6 million people worldwide, and the number doubles every 5 years after the age of 65. It occurs mainly in the old age group, but younger people may also get affected. And as the cases are increasing, it causes additional burden on the healthcare system. The important is the degenerative process in Alzheimer's probably starts many years before the clinical onset of the disease. As this shows here, starting from normal person to a stage of dementia, there will be a stage of pre-symptomatic stage, early MCI, minimal cognitive impairment stage, and late MCI stage, which will take almost many years. There are a lot of studies and researches on Alzheimer's disease and related dementias are going on. These studies particularly are around all the issues around Alzheimer's, such as disease mechanism, care and care-given support studies, population studies, research of infrastructure studies. But out of all these, the studies and research related to biomarkers and prevention and treatment are very important, and they are very widely going on. Drugs such as donepezil, rivastigmine, memantine are in use for dementia and Alzheimer's patients even in Kuwait. In July 2023, FDA approved the monoclonal antibody-based drug called Leqembi, which is a monoclonal-based drug treatment, and currently FDA is reviewing many other similar drugs. But the important is, Leqembi does not cure Alzheimer, but it slows the progression if the treatment started during early stage. Now, out of all this FDA recognition, the interest towards Alzheimer has quadrupled all over the world. But there are challenges for Alzheimer's disease. First of all, diagnosis is not easy. Difficulties in diagnosis due to heterogeneity in pathobiology, genetic factors, brain resilience, and clinical presentation. Alzheimer's disease frequently co-occurs with many other neurodegenerative and vascular diseases, particularly in aging brain. Early and differential diagnosis is important for appropriate care, support, and treatment. And patient may have progressed to a later stage at the time of diagnosis. The other important part is the clinical trial, because all the clinical trials have focused mainly on early stages of the disease. Now here comes the importance of biomarkers. Here this shows the Alzheimer's disease brain, and the main pathological hallmarks are plaques and tangles. The plaques are made up of amyloid beta amyloid protein, which occur between the neuronal cells, while tangles are made up of tau protein, tubulin-associated unit proteins, and these tau proteins are inside the neuronal cells, and when this tau protein gets phosphorylated, they become twisted filaments, and they develop inside the neuronal cells, while the plaques are made up of amyloid beta protein, which can be either 42 or 40 amino acid residues. So this is a list of some of the biomarkers. There are more than that, but these are the common ones, and these are studied very, very well so far. Out of these, amyloid beta protein, 42 and 40, tau proteins, which is total tau, and phosphorylated tau, P181, 217, and 231. These are the site at which these proteins are bound to the chromosome. And neurofilament light polypeptide, NFL, apolipoprotein E4, which is a genetic marker, just to know the potential risk, neurogranin, which is a marker of synaptic junction, biomarkers of neuroinflammation, such as interleukins, chemokines, progranulin, YKL40, and other protein markers, such as epidermal growth factor, alpha-synuclein, base 1, and other lysosomal proteins. So this is a smaller list. The list is bigger, but these markers are very widely studied. And out of this shows some other marker as well, which includes markers of neurovascular injury, lipid markers. But out of all these markers, the important ones, which are very widely studied and which are used in clinical practice, routine practice at present, these are amyloid beta protein 4240, tau proteins total and phosphotau, and marker of axonal damage, which is neurofilament light. So these four markers are widely studied, and they are used in routine practice at present. For estimation of these markers, the body fluids, CSF and blood. Out of this, CSF is of course the best biofluid because it is in direct contact with brain. So many proteins are present in comparatively higher concentration. Blood, though easier to get, but blood biomarkers are very useful, but the concentration is significantly lower than CSF. There are so many techniques are used and tried at present. Techniques based on electrochemiluminescence immunoassays, based on ELISA, based on ELISA with PFA technique, photo-oxidation-induced fluorescence amplification technique, IMR, immunomagnetic reduction technique, SIMOA, single molecular mass analysis technique, quantitative RT-PCR, reverse transcription polymerase chain reaction, and mass spectrometry based on LC-MS-MS and UPLC-MS-MS. About the technique, the estimation of the main markers, amyloid beta protein 4240, tau total, phosphotau 181 and 217, and neurofilament biomarkers in CSF and blood are mostly based on immunoassays. The important part is here, the FDA has so far recognized the technique of electrochemiluminescence immunoassay of Roche and Pfizer bio companies in CSF. The markers in blood are so far not approved by FDA, but blood markers based on the techniques of ELISA, PIFA, and IMR, and some other techniques in blood are approved by CE only. Even though certain laboratories in USA as well as in other parts of the world have started giving service for blood biomarkers. Now, these are some of the findings of the studies done in this field regarding markers amylose beta protein 42 and 40 in CSF. This study shows that this marker can differentiate normal patient from Alzheimer patient at a cutoff of 0.325 at quite high sensitivity and specificity. Amyloid beta protein, when combined with tau protein, can differentiate in from blood sample. This can differentiate patients of normal patient from Alzheimer at a cutoff of 455 with quite high sensitivity and specificity, while the sensitivity and specificity is lower for differentiation between minimal cognitive impairment and Alzheimer's disease at a cutoff of 642. Plasma biomarkers are studied versus CSF biomarkers in Sweden and Taiwan, and these reports show that the plasma or blood biomarkers, amyloid beta protein 42/40 at a cutoff of 0.253 has a sensitivity, specificity, and area under curve very, very good, more than 0.9. And when amyloid beta protein 42 is combined with tau protein, the sensitivity together is also excellent, but at the cutoff of 423. The studies done in various countries such as Taiwan, Japan, USA, Sweden, China, for more than 100 or more than 1,147 patients at more than 20 sites have shown that the agreement between plasma biomarkers and clinical diagnosis is in more than 80% of cases. Some of the studies done in blood biomarkers have shown that the blood biomarkers at certain cutoff can differentiate between a normal patient and a patient having MCI, minimal cognitive impairment, at a cutoff of 382 if these markers, combined markers, are used. And at the cutoff of 455, these combined markers can differentiate patients of Alzheimer from MCI patient. These are the studies done in various places, and this is their findings. So the fluid biomarkers are very useful, a lot of advantages that they can reveal the changes that precedes MRI and PET, as well as ocular abnormalities. As you know, the PET, FDG PET is currently the main marker used in all over the world, but in fluid biomarkers has also revealed that the results of fluid biomarkers can show the changes earlier than PET and MRI. Amyloid beta protein 42, phospho-tau, and total tau have high diagnostic accuracy, especially when used in combination of this marker. Combination is important here. It can diagnose Alzheimer's disease in earlier stages and possibly in pre-symptomatic stage as well. The clinical trials for drug development, because most of the interests are focused on clinical trials. The clinical trials for drug developments are in that these fluid biomarkers are very useful to track the effect of therapies. This shows that the concentration or magnitude of fluid biomarkers also increase as the disease stage of Alzheimer's progresses from normal to pre-symptomatic to minimal cognitive impairment to the final stage. So as the stage proceeds, the concentration of biomarker also increases. For estimation of biomarkers out of these two fluids, blood and CSF, the results from blood have shown excellent correlation with PET positivity as well as corresponding concentration with CSF. The use of PET and CSF sampling is limited because high cost and both of these techniques are invasive, while blood sampling is very easily performed. So this shows that the blood sampling, blood specimen is very important, very useful for fluid biomarkers. Even though all these advantages are there, but there are certain limitations. Biomarkers alone are not sufficient. Biomarkers have to be used for diagnosis of Alzheimer's together or as a supplement with clinical assessment and other diagnostic informations. As reported in many studies, combination of CSF amyloid beta protein and CSF tau protein results are indicative of Alzheimer's disease with sensitivity of 71 to 95% and specificity of 44 to 87%. All these findings show that there is a high variability in different findings. The sensitivity can be even lower during prodromal phase of the disease. So the future research developments are continued. The research for, or the search for the novel or better biomarkers for, particularly for early stage of Alzheimer's is definitely required. The more effective sample preparation procedures, preferably the procedures which involve, which are antibody independent, such procedures are in developments. Further developments in immunoassay techniques are also going on, and more automated MS/MS platforms with improved sensitivity, LC separation, and high throughput are required. Now, what is being done in Kuwait? What is the future of these biomarkers in Kuwait? As I told you earlier, in Kuwait at present, whenever a person has dementia, all these tests which are in blue, these are done. Up to the blood test. Blood tests are done to know the reversible causes of dementia, particularly, as I told you, vitamin B12 deficiency and others. For that, these are done. So as a first step, these are done by the specialist, but the CSF and blood markers, biomarkers are not available at present. We at Ibn Sina Hospital Laboratory have started our efforts to provide service for the biomarker estimation for blood as well as CSF. As an initial mandatory procedure, we will be evaluating 3 analyzers during next few months to find out suitable system for MOH patients. These three analyzers or the systems are, the one is Euroimmune analyzer, which is an ELISA analyzer. It can analyze CSF as well as blood sample for biomarkers, amyloid beta 42 and 40 proteins, total tau, and phospho-tau 181. The second one is Absol HS, which is high sensitivity, portable ELISA system using PFA, phosphooxidation-induced fluorescence amplification technique. This analyzer can analyze the blood sample for all these biomarkers, beta amyloid, amyloid 42, 40, phospho-tau 181, phospho-tau 217, and neurofilament light. The third one is this analyzer, which is MEG-Q analyzer, which is based on immunomagnetic radiation technique, immunomagnetic reduction technique. And this biomarker, this analyzer analyzes the blood sample for amyloid beta protein, amyloid beta 42, and tau proteins. So for preparation of this talk, I have gone through all these references. Thank you very much. Thank you.
Now I'd like to introduce Dr. Devaki Nair. Dr. Devaki, she's a professor in cardiovascular prevention and health inequality, University College London, Royal Free London, and Health Service Laboratories London. Professor Devi Nair is qualified from Madras Medical College, India, and completed her postgraduate studies at the Royal Free Hospital, London. Her special interests include familial hyperlipidemia or hyperlipidemia of genetic origin. As an academic with University College London, her research interest includes lipids, cardiovascular disease prevention, and renal disease. She is the specialty lead for the Health Service Laboratory that serves 4 major hospitals in North West London.
Thank you for the kind introduction. Thank you again to the organizers for giving me this opportunity to be here and to present this. When Dr. Ahmed first sent me the email and asked me to give this talk, I was a bit apprehensive. I said, what do I know about AI? Then realized we in the laboratory do more AI than any other clinicians in small or bigger way without realizing that it is AI. And I, then started learning more about it, what I'm doing, if it fits in with AI, and then realized perhaps we know a little bit about AI. However, I think if we don't, chemical pathologists or biochemists, don't get to know about AI, we will be left behind. And I would urge that any pathology program should include AI in the training and even in undergraduate syllabus. So my objectives would be to discuss the role of personalized medicine in prevention, diagnosis, and treatment, and how it is tailored to an individual in contrast to the conventional medicine where a single strategy is applied. Define artificial intelligence. They're related. Personalized medicine and artificial intelligence slightly related. Discuss the relevance of artificial intelligence and machine learning in laboratory medicine and diagnostics, and understand the potential value of artificial intelligence in laboratory diagnostics. And I will also include an experience of working with a company doing artificial intelligence so that I can share my experience. So let's concentrate on the personalized medicine as first part of my presentation. So if you look at the traditional medicine, we look for medical history, family history, we have a working diagnosis from these, we look at comorbidities, we look at the laboratory, the diagnostics, then the drugs, and also the environmental factors. And if you look at the electronic patient records, 70% of the electronic patient record consists of the laboratory and radiology investigations. So we do contribute in a big way to the electronic patient record and therefore to the management of the patient. Now there is an expansion of the omics, genomics, epigenomics, transcriptomics, proteomics, and metabolomics. So all these profiling has contributed to personalized medicine, personalized treatment. So it helps in the clinical evaluation, incorporation into the diagnostic algorithms, and making you take a treatment decision. So all started with the publication of the human genome sequence in 2002. The interest came for the personalized medicine. And it does not depend on the concentration of a single marker in the blood, like we are used to looking at kidney function, creatinine, urea, etc., liver function, the enzymes, etc. But now we are looking at the molecular marker and lots of biological markers to define the person's ill health or health. Depends on changes in the profile of markers that characterizes each patient rather than applying to the population. Includes expected response to the therapy, to the disease, as well as expected response of the patient. So it's not the therapy only, but also the patient. It provides more effective selective diagnostics, so what is particularly suitable for that single person, and with more effective and safer treatment which we can institute. So high throughput omics were developed recently, and the growth of personalized medicine which provides better outcome, higher quality of life, and improved cost effectiveness. So if you look at personalized medicine, modern technology can acquire large number of profiles. And if you take a urine sample and profiling the biological nature of the urine sample, there can be 2,000 or more proteins and peptides in that, and there are technologies available to look at that. And it covers all the cell biology, genomics, transcriptomics, proteomics, lipidomics, metabolomics, epigenomics, and microbiota, which also change our internal environment. So all this contributed to health or ill health. And there are facilities for us to look into these. And if you look at the old days, we looked at kidney or hepatic function, which changes, but the characteristic of the DNA do not change. So that defines the person. And if you look at, again, the pharmacogenomics which is developing, we're looking at adverse drug reaction related to changes in the genes. And by incorporating the genetic information into management or in the treatment, we enter into a field of individualized treatment for a person, which we call as the patient-oriented medicine or personalized medicine. Now, the focus is on patients on a holistic approach of that individual, which is predictive. So some of these will give predictive value to making the diagnosis, preventive value to making the diagnosis, personalized, and participatory medicine, which is now called as the P4 medicine, which is in contrast to the conventional medicine. So in the conventional medicine, we are reactive to symptoms, we are reactive to what is happening to the patient, and it's a unified approach. But in the P4 medicine, we look at a holistic approach. And therefore, we may have to revise the role of the laboratory medicine in the healthcare system to suit this P4 medicine. This is especially, we're seeing this especially in the cancer treatment, which demands genome and phenome-wide approaches with a focus on patients and their involvement in the treatment decisions too. So now we're moving away from one size fits all, and even if you look at the drugs, the same dose cannot be given to everyone. The same drug cannot be given to anyone. The response may be excessive and associated with adverse drug reaction in some, and some it may be too weak and they may not respond at all. And it can be followed by additional clinical complications which can worsen the condition, and also the outcome could be bad. So if you look at the genes, the contribution for these responses is up to 30 to 95% for drug-related side effects or drug-related adverse reaction. So mutations can alter the pharmacokinetic and the pharmacodynamic properties of these active substances, and the change in the expression can result in adverse drug reaction. So if you look at Europe, 3.6% of all hospital admissions are due to adverse drug reaction, and the adverse drug reaction occurrence rate during hospitalization is up to 10%. So again, personalized medicine or the P4 medicine might be a better one, and we have to change the diagnostic medicine, will have to change to help that. So the laboratory medicine gets more complex, becomes multifactorial, requires accurate interpretation. We're not looking at one analyte saying reference range, this is high or low. We are combining several proteins, several peptides, several molecular markers, where we need support of information and communication technology to interpret the result. And this is where the AI would become useful. And we all need the skills for data interpretation as well. So I'll pull out two examples we're already doing. You know about the TPMT testing, which we do for the purine drugs, which are metabolized by TPMT. We can genotype, we can measure TPMT. When you genotype, the patients who have non-functional gene, which has very low activity or deficient activity of TPMT, we have to consider alternate reagents for them, for azathioprine, 6-mercaptopurine, and thiaguanine. You look at all these drugs are purine analogs, and when you don't have enough of the TPMT, you're not metabolizing these drugs, and toxic effects are seen in these patients. So you may have to, when you genotype these patients, when you measure the TPMT, you may have to change the regime or use alternative drugs and so on. And you can have 2 or more functional alleles, which gives an intermediate effect. Again, you may have to halve the dose, and you may have patients with 2 or more functional genes when it works very well, and you can use the normal dose because you can metabolize the drug appropriately. So this we've been doing for quite some time, the TPMT measurement. So personalized medicine is already crept into our diagnostic labs without us realizing it's personalized medicine. And if you look at another dihydropyrimidine dehydrogenase measurements, again, the genetics associated with that for fluoropyrimidine drugs, again, you have a genotype, and you have the SNPs detected from that, which relates to the function of these enzyme, and therefore how drug is metabolized and choosing the right drug for the right patient. So again, another example where the laboratory is already providing personalized medicine. And you may also know there is a variant, SLCO1B1 variant, which is responsible for statin-induced myositis. It's not widely available like these two investigations, which is widely available for clinicians and from the diagnostic laboratory. But again, this will also help us to pick up those patients who cannot tolerate statins. Statin intolerance is very common, and sometimes they stop all the statins, and having this slow B1 mutation will tell us that the patient cannot tolerate the statin. We'll be able to use alternative agents for these patients. So moving on to my second part of the talk, artificial intelligence. So what is artificial intelligence? It's used to refer to machines that mimic intelligence, human cognitive function for problem solving. So instead of the human being, the machine is solving the problem for us. But it cannot do by itself. We have to train the machine to solve. So a man is behind that to teach the machine, and you teach the machine by providing the data, and then this trial data is fed, and then you come up with this, and then you apply that. The trial data which you use should not be used for publication. Sometimes you see publications using both, but that shouldn't be the case. The one which you use for the machine to learn should be separately analyzed from the data that we use on a regular basis. It uses predictions, automation to optimize complex tasks. We're already doing that in the laboratory. There are complex, repetitive tasks which we have made the machines understand and do rather than us doing in the lab. So it's not something new to the diagnostic laboratory for recognition, decision-making, and translation. Machine learning, deep learning, and the neural networks are all subtypes of this artificial intelligence. And if you go into the details, what they say is the neural network is actually the subfield of machine learning, and the deep learning is the subfield of the neural network. So these are the terminologies which we may have to be familiar with to be at the forefront in diagnostic medicine with artificial intelligence. There are three main categories of artificial intelligence: artificial narrow intelligence, general intelligence, and super intelligence. ANI is considered weak AI, where the other two types are classified as strong AI. But we don't have too many of the AGI and ASI. So the stronger forms of AI, like the AGI and ASI, incorporate human behaviors more prominently, ability to interpret the tone and emotion. If I say, you see, warnings about WhatsApp messages coming saying it can pretend it's you and tell people to do things, to send money and so on. Maybe that is in a small way like that. It picks up the tone and the emotion of the people. Strong AI is defined by the ability to compare to humans. Artificial general intelligence would perform on par with another human, while artificial superintelligence, known as superintelligence, would surpass the human intelligence ability. And neither form of the AI exists yet, but research in this field is ongoing. So if you look at AI, it's defined by computers in healthcare as a simulation of the cognitive function of the human being. It draws inspiration from the biological neurons from the brain and includes the basics of sensing, identifying objects so that machine can compete with or surpass the human performance. Then you worry about, are they going to replace us? But it lacks the articulation and the insight of the human being. So they're never going to, artificial intelligence is never going to replace us as physicians or laboratory technicians, laboratory scientists. Many instances, AI is supplemented by medical judgment without being universally applicable. So two branches, machine learning called the deep learning, that is represented by mathematical algorithms that improve learning through experience. And there are three types of machine learning algorithms: unsupervised, where you supply lots of data and finds a pattern. And it's so applicable for diagnostic medicine picking up the patterns. And if you can provide lots of data and picking up the patterns, coming with a preventative diagnosis or predictive diagnosis. Supervised is classification and prediction algorithms based on previous examples. And there's another one, which is the reinforcement learning. So these are the different types. And if you look at the history of machine learning, Arthur Samuel is credited for coining the term machine learning with his research around the game of checkers. So Robert Neely, who is an expert in this game, when it was set up on the IBM 7094 computer in 1962, he lost to the computer, which means that you train the computer to excel what the human being is saying. So machine learning is a branch of artificial intelligence and computer science, which focus, therefore, use of data and algorithm to imitate the way the human beings learn and gradually improving its accuracy. And more data you feed, more feedback you give, it gets better and better. That's the checkers, and the principle is very simple. If you look at the number of possible games that can be played, which you call it as the game tree size, the number of leaf nodes in the game is 10 raised to the power of 31. And if you look at chess, it's 10 raised to the power of 123, and the Go is 10 raised to the power of 350. So the average branching factor, that is what is the number of legal moves for a given position, is only 2.8. So the checkers is a very simple one. As you move to more complex one, it becomes more and more difficult. So they were able to do this in 1962, so it's not a new concept. The third category is important, the reinforcement learning, where a computer learns by interacting with its surrounding. And getting data, so the data and getting the feedback, either rewards or penalties, so it stops sending the data to the next node. So the diagnostic medicine offers a great potential for this type of machine learning, and online learning is a type of machine learning where a data scientist updates the machine learning model as new data becomes available. And probably in the future, we'll see a data scientist as part of our team in diagnostic laboratory, because it will become more and more complicated for us to manage this as medics unless we specialize in artificial medicine. It's in where we use statistical methods, algorithms trained to make classifications, predictions, to uncover key insights into data mining projects. Manually, we do that. Now, what we're doing is training the machine to do that by feeding the data, so that this big data, which everybody talks about, it will expand, and the market demand for the new data scientists will increase, and the companies are very interested in what we produce. And we have to be careful about what we get involved in these. About the neural networks is again a subclass of the machine learning. Neural networks, called the artificial neural networks, is simulated neural network, subset of machine learning, and the backbone of the deep learning algorithm, which is especially used in clinical scenarios. They're called neural because they mimic how the neurons in the brain signal to each other. So they have nodal layers, an input layer, and a hidden layer, and an output layer. And each node is an artificial neuron which connects to the next, and each has a weight and threshold value. So when one node's output is above the threshold value, the node is activated and sends the data to the next node, next layer. And if it's below the threshold, no data passes. So it's very appropriate for diagnostics, AI development, this neural networks. Training data teaches the neural network and help to improve the accuracy over time. And as I said, 70% of the healthcare data comes from us. And once the learning algorithms are fine-tuned, they become powerful computer science and AI tools, because they allow us to quickly classify and cluster data. Using the neural network, speech and image recognition tasks can happen. And if you look at the Google search algorithm, it's a well-known example of the neural network. A current AI project being tried is with the serum protein protein electrophoresis in our center. They're looking at how we can recognize pattern. That's an example of neural network. So I thought I would, I never knew that I was getting involved in an AI project. At the time when I got involved in this, we were involved in a Google DeepMind project, which is the National Acute Kidney Injury algorithm was launched in a patient safety alert so that AKI can be picked up very early and we can treat people, we can prevent chronic renal disease, and we can prevent patient going into dialysis, and we can prevent deaths. So this was a directive from the NHS England to all the hospitals that we have to report acute kidney injury 1, 2, and 3. In July 2015, from the British Public Hospital, the clinicians from the hospital within the Royal Free approached the Google DeepMind Technology Limited, and an artificial intelligence company with no experience providing healthcare service. These people have no experience healthcare nursing, and they have no experience in dealing with patient data, and about developing a software using patient data from the trust. The DeepMind built a smartphone app by taking all the data from the trust computers. It didn't leave the trust premises. The DeepMind person came and worked with us within the hospital, so the data was safe because we didn't know how to work with it, so the data was safe and erasing, and it was called streams. And the streams, they came up with all the data was fed into that, and anybody who had a creatinine measurement generated an AKI alert using an algorithm, using this data, and that got relayed to the mobile phone of all the junior doctors. And so the junior doctors knew who has AKI. Not all AKI alerts were real, because they still had to look at whether it was real from the context of the clinical data, but they had this data with them, which enabled them to act very quickly, 24 hours a day. So this was really a good, symbiotic relationship with the AI company. And it was solely developed for the national algorithm for AKI published by the NHS. The process designed to assess the rapid diagnosis of AKI from the starting point when a creatinine is measured. So any creatinine measured would generate this and go into the DeepMind and then generate this. These alerts were transmitted to the mobile phones. So the algorithm was standardized by a working group of nephrologists and biochemists. We were all involved in designing this with inputs from providers of specialist laboratory software system from the hospital, and the results being generated by the Royal Free's Laboratory Information Management System. So the alert was generated in our information system, the laboratory information system, and then going on to the mobile one. DeepMind's role was to design the clinical app and to get the alerts generated by this algorithm delivered to the clinicians on the fly. So does not, however, extend to patients who have never been tested for serum creatinine. But what happened was when they're collecting the data, we collected everyone's data, irrespective of whether they had a risk of AKI or not. And it's something because we didn't have that experience, the DeepMind didn't have the experience. So there are issues that came up later on that we should not have done that. DeepMind acknowledged that the algorithm can miss cases of AKI, so there are risks as well which should be assessed, and can misclassify their severity because it's a computer algorithm, so it's not as good as a clinician one, but it just alerts someone. The failure to explain and address these issues, and in particular the disconnect between the trust-wide data set, has been transferred under broad terms of the agreement, and narrow a set of patients who will ever be monitored and treated through considerable doubt on the DeepMind. So people started questioning how we could do that. Luckily, the data stayed with us, but if the DeepMind had taken the data outside, we would have been in real trouble. The Rolf-Rees position that all data being transferred is necessary and proportionate to the safe, effective, and that was our thing. A clear lesson was learned from the whole arrangement, is that attempts to deliver any public health service should not be launched without understanding the details, the documentation, the approval, and the legal bedrock of the partnership that underlie them, even with the public. The public should be informed because it's their data, it's not our data, it doesn't belong to us. So the public should be part of that. This lesson applies no less to the companies offering algorithmic tools on big data sets like pharmaceuticals or biotech companies. Because pharmaceuticals, we are very strict. We don't hand over data. We have to be careful. These AI platforms, AI companies, we should treat them exactly like the pharmaceutical companies or the biotech companies. They are no different. Simply using health data for the purpose of speculative and abstract medical purpose will not satisfy the data protection law. So you're not satisfying the data protection law by saying that. So this is where the medical information governance architecture, the so-called Caldecott principles and the guidelines in UK come into play. And the data protection law relies on key distinction between the data controller and the data processor. So the data controller is defined as a person who determines the purpose for which the manner in which any personal data are processed, while the data processor is the person who processes the data on behalf of the data controller. So you need to define that. I'm involved in another project setting up a FH database, and Royal Free has a third party who is the data controller. Now we are trying to take over the data controller. The trust is taking the data controller as well as the processors, so that there is no conflict of interest, a third party being involved. So if you look at the DeepMind for individuals who are escalated to the clinical intervention based on this algorithm, after a preliminary, this direct scenario applies. So only for those, this applies. For the rest whose data has been transferred to the DeepMind, no plausible necessity for the DeepMind's processing of the data occurs. But you're putting it all onto the system in the artificial intelligence part of this Google DeepMind. This particular case study and the way it is unfolded demonstrates a clear absence of strong tools necessary for the companies to account for the same way as the public institutions, even if they aspire to deliver, in some case, overtake the public services. So we have to be very, very careful about this. Network of information now rule our professional and personal lives. And if you look at all the companies, principally owned and controlled by a handful of US companies, Google, Facebook, Microsoft, Amazon, Apple, and IBM, new players are unable to get in the way these people are getting in. And the newer digital companies are afforded the opportunity to extend these networks into other domains. They will limit competition there too. And that's what the stake with the DeepMind being given unfettered, unexamined access to population-wide health data statistics, which can happen, and it will build, own, and control the networks of knowledge about diseases. So we have to be very careful. And the value embodied in these data sets don't belong exclusively to the institution or to the specialists who can make the deals. It belongs to the public who generated it in the course of the treatment. And there is a pressing need for any organization to consult broadly on the value of these data aspects, of these transfers, and ensure that the public gets the best possible value of any deal. A large digital companies certainly have the potential to improve our healthcare system, given the sensitivity of the public trust in emerging technology. In order for the innovation to deliver over long term, it must advance in a way that meets and exceeds the regulatory framework that is existing and the societal expectation of fair treatment and value. Not doing so will only hinder the adoption and growth of beneficial technology. Is it time? Is it time? And I can stop now because if I go into a little more details, it says. So hopefully I have shown you an example of an artificial involvement in an artificial intelligence project, the problems associated with involving another company and how things can be difficult. The only way we can prevent that is by us educating ourselves. I've learned from the deep mind, so I'm very careful when I do the FH project. So the role-free is also now taking the control of everything and getting help, to get the technological help so that we don't hand over the data to anyone. Thank you.
Thank you so much, Dr. Devaki, for your informative lecture. Once again, we'd like to remind you, if you have any questions, scan the QR code on the podium and submit your answers. The questions will be discussed at the end of the session. Next, we'd like to welcome Dr. Daniel Holmes. Dr. Daniel Holmes earned his undergraduate degree in chemical physics from the University of Toronto. He went to medical school at the University of British Columbia, where he also did his residency in medical biochemistry. He is a clinical professor of pathology and laboratory medicine at UBC and head and medical director of the Department of Pathology and Laboratory Medicine at St. Paul's Hospital in Vancouver, and interim medical director of the British Columbia Provincial Toxicology Lab. His interests include clinical endocrinology with a focus on secondary hypertension, lipidology, clinical mass spectrometry, and data science, and application to data automation, visualization, and clinical utilization. Let's welcome Dr. Daniel Holmes.
Thank you so much for the kind introduction, which I don't deserve. And I had to go back and get my glasses. My former trainee, Dr. Ahmed, and I were lamenting the other day that when you cross 50 years old, everything is falling apart, and you can get injured just by sleeping the wrong way in your bed. Wake up in the morning, can't move, and I can't see. I'm going to talk to you about indirect reference intervals and explain what those are, and talk about old and new methodologies for doing indirect reference intervals. So let's talk about what an indirect reference interval is. An indirect reference interval is when you don't want to do a reference interval study. You want to use archive data from your routine labs to establish or confirm a reference interval for an analyte of interest for you. So, for example, you might have had crude reference intervals for a while, but now you've run a whole bunch of tests and you want to refine them and see if you can make your reference intervals better. So you use your old archive data to establish reference intervals. Or you might have data over a network, and you might want a common reference interval between everyone in your network on a test that more or less works the same between different instruments. And so you pool everybody's archived data for whatever test you're interested in, and you apply statistical techniques to establish what the reference interval is. Now, there's a few different approaches. One approach is to take electronic health record data and exclude anybody who has a medical condition that might affect the normal range. And then just once you've purged the data of anybody who has this disease state that might affect their results, then you just do normal reference interval study on the remaining data that you've cleansed. But another approach is to not bother to purge unhealthy patients from your data. Let the data speak for itself. And there's certain scenarios where that works pretty well, and that's what we're going to be talking about today, these statistical methods for indirect reference intervals. So they're particularly useful in lab-developed tests, because if you've done a whole bunch of validation data, and you have a bunch of archive data, but you don't have a specific reference interval study, it can be helpful for you to establish a reference interval on a lab-developed test, which is what the acronym LDT stands for. So we might have a lot of old data that we can make good use of. And how do you do that? How is it done traditionally, and how is it done in the modern sense? So the very first method for establishing an indirect reference interval was called the Hoffman method, and was published in JAMA and it was called Statistics in the Practice of Medicine. It was a very simple approach, and in a mathematical terms, this is called Gaussian mixture model deconvolution or decomposition. So the picture will show what we mean. Here's kind of what we are after. On the left-hand side, in the green mode, we see the normal portion of the population. In the right-hand side, in the red mode, we see the people who are unhealthy. And you can see that the healthy people and the unhealthy people kind of overlap, so that's the confusing bit. This is a lot like chromatograms that overlap in mass spectrometry. So we can imagine if we could infer the green curve and the red curve from the aggregate data. We only have the aggregate data. We don't have the green curve and the red curve. We want to figure out what the green curve and the red curve are. If we could figure out what the green and red curves are, we could infer the normal range from this data, which is a mixture of unhealthy and healthy people. So Hoffman came up with a very simple procedure to do that. So his procedure was to take the data and prepare a normal probability plot or a QQ plot. Now, that's not what he called it. He called it plotting the distribution in normal probability space. But in modern statistical terms, this is creation of a QQ plot. So here's what the QQ plot looks like. I think you've seen that QQ plots are a way of establishing whether a distribution is normal, and the straighter the line of a QQ plot, the more probability that the distribution is normal. But we know this distribution is not normal. We just looked at it. If we go back, it's not normal. It's got two modes in it. So we can see that that bend in the middle of the curve is the place where the second unhealthy mode begins. The Hoffman procedure is to take a straight line and tangentially draw from the first mode and extend it up, and then draw horizontal lines at the plus and minus 2 SD marks and find out where that intersection occurs. Now, maybe I can get myself a mouse here. So you extend this straight line, which is the healthy mode, and you see where it intersects with the plus or minus 2 SD marks, and that point there is the upper limit of normal, and this point here is the lower limit of normal. And so for this particular imaginary scenario, the reference interval that is inferred from that data is 3.15 to 7.37. But something got lost in the clinical chemistry literature shuffle. And in the 1980s, people forgot that you needed to plot this on normal probability paper. That was a big mistake. You have to plot this in normal probability space. You have to do a QQ plot. You can't just plot the cumulative distribution function. But anyways, a well-known person published a number of papers making this error, and then the error propagated through the literature, and people started copying it. To this very day, this incorrect approach is copied, and it's most unfortunate because it results in reference intervals that are too narrow, as I will show you. So it affects many publications, and the incorrect approach has actually become quite popular. It's kind of tragic. So it even appears in the American Association of Clinical Chemistry textbook of pediatric reference intervals. That is not a QQ plot. That is just a regular cumulative distribution function plot, and it's not plotted in normal probability space. And if you extend that line, you do not get the normal range. So let me show you what I mean. So this is the correct way of doing the Hoffman method, where you prepare a QQ plot of your distribution and you extend this line. In this scenario that I'm showing you, the green vertical line is the true value, because I did this with numerical simulation. So the green vertical line is the correct result, and this value here is Hoffman's estimation. So it's out by a little bit. That's about 7, and that's about 7.5. And these ones are a little bit closer. The vertical green line and the vertical dash line are very close. If you don't plot in normal probability space, your answer, which is incorrect, is the vertical dashed lines, and you can see that you get results that are further away from the green values. And this, as I say, has propagated through the literature, and and it's unfortunate, but the great thing is that Roche Diagnostics has made some helps for us. We're going to talk about those. So if you do the Hoffman method the incorrect way, you don't get mean plus or minus 2 SD for your result. You get mean plus or minus 1.19 SD. You can calculate that exactly. And what that means is all the reference intervals you will get if you do the Hoffman method wrong are too narrow. And so this is illustrating the same thing that I showed you before. So the red lines are what the incorrect approach is going to give you, and the results are always too narrow. So what does it mean? It means different things in different scenarios, but as I said, most of the time it means the estimated reference interval would be mean plus or minus 1.19 SD instead of mean plus or minus 1.96 SD. So illustrating this point, we can take this is a distribution that is very well resolved, right? They're not overlapping. The sick people in our population, that little mode on the right, and the well people are this mode on the left, they're very well separated. And so you can apply the Hoffman method and you get almost perfect results. And if you apply the incorrect approach, you get results that are, in this case, again, too narrow, because the green vertical lines are the correct values. Okay, so enough about making mistakes in the Hoffman method. So what are the alternatives? We can do the Hoffman method correctly. That's one approach. You can also do this other method that was developed from the fisheries industry, believe it or not, by a gentleman named Bhattacharya. And it is another procedure for doing inferring reference intervals indirectly from data that you have. It is another graphical method. It's a little bit harder, but I've written source code for you if you'd like to use it. I'll be giving the reference to it later on. But the Bhattacharya method is the other approach. But there are modern approaches. The nice thing is that there's a whole bunch of modern approaches, and now the barrier of entry for using those modern approaches as implemented in the R and Python programming languages is quite straightforward. So this problem of deconvoluting Gaussians that are overlapping is not unique to clinical chemistry, right? I already told you that it was present in chromatography, right? Chemometrics. It's present in physics. So it's a very universal problem, and it's been addressed by a lot of other scientific industries. So there's no reason why we should, as a field, gravitate to the Hoffman method at all. In the R programming language, statistical packages are produced separately from the core language. Excuse me. And if you want to use those extra statistical packages, you have to download them, but they're quite straightforward to download. But here's 3 different packages that will do this kind of Gaussian mixture model deconvolution, and it's quite easy. Here's an example. These are I don't know if anyone's ever been to Yosemite National Park, but there's a geyser there called Old Faithful. Old Faithful erupts its water out of the geyser in a kind of unpredictable way, in the sense that sometimes it takes about 80 minutes and sometimes it takes about 50 minutes, and it forms this bimodal distribution. And we can apply the Hoffman method or the Bhattacharya method or any other method to deconvolute those 2 Gaussians. And so that's the code that produces that picture there. Now, I'm using this mixed tools package from R. This is the entire code to do this work, okay? This is like one line. I'm telling it that I've got a normal mixture model. I want to apply it to the Old Faithful's waiting times, and I want two modes to come out. So when it finishes everything out, it finds that the mean of the first mode is 54 with a standard deviation of 5.87, and the mean of the second mode is 80 with a standard deviation of 5.86. So very, very easy to apply this mixed tools package to data like this. And so that's our result. And even if you have skew data, because I've been talking about an overlap of Gaussian curves, we all know that very often our data is not Gaussian in nature. Our data is skewed, and so we can't just apply Gaussian tools to them. But this mixed disk package, for example, allows you to fit skew data. So this is TSH data, And I've asked for 3 modes in my TSH data. So it's got a little tiny mode there for the hyperthyroid people. It's got a wide blue mode for the euthyroid people. And it's got this green mode for the hypothyroid people, and it's an overlap of 3. The other approach that you can do is try to do a normalizing transformation on the data first, which is the approach that Roche Diagnostics uses in their package, and I'll show you that in a moment. But these are called expectation maximization, maximum likelihood methods for deconvolution of Gaussian mixture models. There are problems. Depending on how much outlier data you have, you might have trouble getting the model to converge for you. And you might have to trim those outliers, and whenever you're trimming outliers, you're going to be making a value judgment, and you have a tendency to try to coerce the data into giving you a result that you think you ought to get. For example, if you're looking at TSH normal range, you might coerce the data to give you a value for the normal range of TSH between 0.5 and about 5. And so you don't want to fall into that trap of trying to get the data to say what you want. And you can also do some sanity checking on any results you get by doing quality assurance checks at the end to make sure that you haven't done anything that isn't really honestly expressed by the data. But there is a new approach to this. There's another method, and the method comes from Roche Diagnostics. So Roche Diagnostics looked at this problem, and they said, this is a problem that we know how to solve mathematically, and it's a problem that we are going to take on. And so they published this method called Refiner. And it's described in this paper here. Lead author is Tatiana Amr, who's been very helpful. And the Refiner package can be just downloaded into the R programming language, and I'll show you how you use it. So, I have taken, by way of example, let's see if I can get my mouse. I extracted 21,000 AST results over 3.5 years. And this is the code that you write to do this. So first you load in the Refiner package, and I think you can see that it's not too much code here. So this says that the reference interval is, I invoke this function find reference interval, and I give it the data, I give it the AST data that I have produced, and then I print the values, and I say I want the 2.5th percentile, the 50th percentile, and 97.5 percentile. I could do the 5th percentile and 95th if I like. And let's have a look at what comes out. So what spits out onto the screen is that the reference interval lower limit is about 9. The upper limit is about 42. That's pretty good. And there's some unfitting parameters that we won't go through what they mean, but they have a specific meaning. Now, I do want to point out one thing. The Refiner method always does a normalizing transformation on your data. So it will pick the transformation that will make your distributions as normal as they can be so that the assumptions of the model are best fit as they can be. So it does a Box-Cox transformation, and that's what the lambda is referring to right here. That lambda refers to the Box-Cox transformation lambda. Box-Cox is a generalization of the logarithmic transformation, so we all know that we can make data more normal by taking its log, but there's a generalization of the log function, which is the Box-Cox transformation, and that's the value for the transformation that it undertook before it did the analysis on the data. So here is what we get out of our code. So the gray is the entire distribution of data, and I didn't pull out any abnormal people, right? I just threw all of the data at it, and it did a normalizing transformation under the hood, and it inferred that the green mode is the normal range, And anywhere you see red, those people are considered abnormal. So there's abnormals away out here, and there's abnormals down here, as we would expect. These are, I guess, people that are, unexpectedly small livers or something like that. And then our central mode is right here, and then it generates this value of 8.98 to 42. Now, I know that not everybody is a computer programmer, but you can just cut and paste this code in and change AST to whatever you want it to be, and you can give it a shot on your data. So here's another example. We're going to use TSH in this case, and we're going to, again, search for the 2.5th and 97.5th percentiles. And what do we get? Pretty good, really. 0.56 to 5.15. Now, why is it 5.15? It's 5.15 because I haven't removed anybody who has antibodies from the data set, right? If you have antibodies to antithyroid antibodies of any type, you have a little bit of thyroid autoimmunity, and you can become a little bit more hypothyroid. And so if you pulled all of those people out that had positive thyroid antibodies, that would be a tighter reference interval for you. But the purpose of these methods is that you don't have to pre-massage the data. You don't have to purge the abnormal people out. We're going to infer their values from the distributions. And so in this case, we can see that the lambda that's chosen is 0. That means it used a logarithmic transformation. And we get a pretty good value for the central mode of TSH, and this is what the data looks like. You can see here the hyperthyroid people. And then out here, of course, are the hypothyroid people. And then in here are the euthyroid people, and the calculation comes out all by itself. What about cortisol, 24-hour cortisol excretion? Now, this is an example where we're going to apply it to a lab-developed test. So we've been running cortisol, 24-hour urine cortisol for quite some time, and then there arose a literature that said the 24-hour urine cortisol values for reference intervals should be different between men and women, rather than just using a generic one. So this is a very easy way to take your old data and quickly evaluate whether you should have a different reference interval for men and women. Now, I don't think I did that here. I think I just threw all the data in by way of example. So this is what I got. I got a value of 10 to 144, which is actually pretty reflective of the literature. And the older literature would have the upper limit of 24-hour urine cortisol to be around 200 micromole per day. And this is at 144, which match what we were using. And I used, in this case, not that many data points, really, 1,829 data points. So it's an easy way to validate or to check on what you're doing. So the literature has value of about 120 if you do a true reference interval study. The old literature was around 200 for that value, and we're getting a value of 144 per day. Not bad. Maybe you wouldn't want to use it. Maybe you'd want to do a proper reference interval study. But one of the value propositions in doing this kind of work is to, if you've done a smaller reference interval study and you want to see if you're just way off, or whether you just want to get a quick validation of your reference interval study, this is a way to do it. There are other new approaches. So there's this other approach called Cosmic. It's very similar in its approach and similar in the kind of results that you get. And so you can apply the Cosmic method also. Similarly easy, in fact. One thing I've found with Cosmic is that its convergence is much slower. Cosmic replaces a software package that was produced by the German Society for Clinical Chemistry that was doing this kind of work, indirect reference interval, and this is the sort of evolution of the software that they had produced and had made available on the DGKL website. So you can give that a shot. Now, the University of Toronto has worked pretty hard with both Cosmic and Refiner to do the following, and I think it's a pretty interesting idea, and you could entertain it in some of your hospital networks. So let us suppose that you have a hospital network with, say, 15 hospitals in it, and each hospital has a different vendor. but the analyte is one of the analytes that's pretty standardized from vendor to vendor. So maybe ALT or something like that, or alkaline phosphatase. And each institution, having its own clinical biochemist or medical biochemist, has set up its own reference interval. So in your network, you have this confusing thing where doctors are working at different sites, but they're getting different reference intervals for the same test. Now, when you all come onto the same electronic health record, people start to get annoyed about this kind of thing, that the reference interval from one hospital and the reference interval from the other hospital might be different, even though they might even be using the same vendor. So this indirect reference interval approach allows you a way forward to get harmonized reference intervals between sites. So if you look at the publications from Khosrow Delhi from University of Toronto, he's been working very hard to use this to make standardized or harmonized reference intervals, I should say, between hospital sites. So it works like this. All of the hospitals pool their ALT data. They're all using methods that are very similar to one another. All the data is pooled. You do the indirect reference interval analysis, you get out a result, and then you go back to the raw data and you see how much reclassification it's going to result in. If you only get small degrees of reclassification, you've got a pretty good argument for having a harmonized reference interval between those multiple sites. Now, it's not going to work for everything. It's going to work for analytes that are very well standardized between the different methodologies. And so that's something you can consider to help yourself get to a place where you can have harmonized reference intervals irrespective of your hospital site. I do want to give one other caution about this too. Originally, I tried to do this to get reference intervals for IgG subclasses. IgG subclasses is a test that you use for IgG4 related disease. And because there's 4 analytes, doing a reference interval study becomes, quite a lot of work, right? You have to have, say, 120 people on 4 analytes, and if there's any age dependence, which there is, then you're going to have even more complication with that. So we took all of our old IgG4 data and our IgG4, IgG3, IgG2, we pooled that all in and see what we got. Now the problem is we got reference intervals that were way too wide with this refiner or cosmic method. Now why? The reason is because most of the people that are being evaluated for IgG4 in our institution are people with known IgG4 related disease. So what this is going to give me is the normal values for people who are treated for IgG4 related disease, the central 95% of people treated for IgG4 related disease. You don't want that, right? So you have to be mindful of the population you're putting in. So one of the things you can do to improve Cosmic or Refiner or Bhattacharya or Hoffman is try to focus on, try to purge out data that you know that these people are for sure certainly diseased. That can help with the analysis because even though in principle you don't need to do that, it can help the analysis produce something better. So in summary, there are the URLs for the Cosmic and Refiner packages. There's the URLs for 3 other packages in the R programming language that will allow you to do this. By far, the easiest of these with the least knobs to turn is Refiner. Refiner is so easy that you really can't make any mistakes because it does all the work for you. The other 3 down below, there are kind of more parameters that you can tune, and then there's more opportunity for you to maybe make a mistake or do something that doesn't make sense without realizing it. I have written, if you do want code for the Bhattacharya and Hoffman methods, I have put it on my own personal GitHub, so you can download that. It's actually very easy to use also, and you can compare what you get from mixed tools or from Refiner to what you get from the Hoffman and Bhattacharya methods. So a few caveats for you. You can't always get what you want out of your data, but if you try, sometimes you might find that you get what you need. I would caution you that you don't want to over-interfere with how these models are working in order to coerce these things to get what you want. You kind of want to put the right data in and let it spit out what it spits out without massaging and doing too much to try and engineer the solution you want. I've given you some harm reduction statements about incorrect application of the Hoffman method. I hope that you will be aware of the literature that does it incorrectly. And I would consider getting rid of abnormals by linking to patient records if you can do that before you apply any of these methods. And if you have perfect execution on getting rid of abnormals, you don't need any of these indirect reference interval methods at all. Hoffman method has been incorrectly applied, and where so, it produces results that are too narrow. Even when properly performed, the Hoffman method is not all that great, and it's time for, I think, for Hoffman and Bhattacharya to go up the great tunnel of light. I suppose they're going to Jannah, not Jahannam. They're going up the tunnel of light. And these modern methods have become quite easy to use, so I would advise you to try them. And I want to thank you very much for the opportunity to come and speak to you about this topic. Thanks very much.
Thank you so much, Dr. Daniel. We have questions for you, Dr. Daniel, so if you'd like to stay. Yeah, we're starting the question session. So they're asking, how can we stratify the reference ranges according to age, gender?
Oh, yeah.
Like pregnant, non-pregnant.
Right. So there's a well-defined procedure for how to, so the question is, how do I decide what bins I'm going to place the data in terms of age to do reference interval study on an age window? So because if you have age-dependent reference intervals, you don't want to just toss all the data in. You want to decide, okay, where am I'm going to do the people from 15 to 20, 20 to 25, or should I do 15 to 20 and 20 to 30? So the method that is established for deciding what the age cut points is the method of Harris and Boyd. Harris and Boyd. And if you look up the paper from Harris and Boyd, it gives you instructions on how to define the age categories. But the other thing you can do that is very practical is you could just plot the reference intervals as a function, the results you get as a function of age, and you can say, well, everybody over 40 seems like it stops changing, and you can make ad hoc decisions like that also. But the traditional approach is the method of Harris and Boyd. That's a good question, actually.
Another question is how to apply this method also for different population in Kuwait, since we have a Kuwaiti and non-Kuwaiti population coming from different ethnic groups.
So, in other words, the question is, should I look at this based on ethnicity?
Yes.
Yeah, so the way to start would be to take your data, and you're going to hang on to your ethnicity as a variable, and you're going to look at the distributions, compare the distributions like with a box plot or violin plot as a function of ethnicity, and see if there's any difference that matters. Now, the nice thing is in clinical chemistry, you can say, yeah, this might be a statistically significant difference, but it's not a clinically significant difference. And if you don't see any difference based on the ethnicity, then you're not going to be worried. What I'd be more concerned is that you'd see a difference based on BMI. You might have reference intervals that are based on BMI, but I'm not sure that makes complete sense, since being really heavy isn't really normal.
One question is about the minimum number of samples to generate an indirect reference range.
Oh yeah, that's another great question. As much as you can is the answer to that question. So you're going to be able to tell when you plot the data, when you plot your distribution initially, if you can't see two bumps because the data is really noisy, then you can't expect the calculation to see two bumps. It's a lot like machine learning and AI. If it's hard for you to see it, the computer's not going to see it either. So there's no right answer for this. As much data as you can, plot the data. If you can see the two bumps, the two modes of the distribution, then the computer can see them too. If you can't see it, and it looks very noisy, your distribution, then the quality is going to be reflected in the results. But there's no way to be sure how many. I would just say I would never try this without 500 to 1,000 data points generally. That's heuristic experience.
Okay. Here, usually we use the manufacturer leaflet to use the reference range. So the question is, Hoffman method recommended to verify this reference range?
Sorry, read the last sentence again, please.
is Hoffman method recommended to verify?
Well, it's a way, yeah. So the question is, if I've got the package insert result, which we know is done on a, maybe a population in Germany for Roche Diagnostics or population in the United States for Siemens, if I got the package insert reference interval, can I use the Hoffman method to validate it? That's actually a really good idea. You can use the Hoffman method or Bhattacharya method or any of these methods to see whether the package insert is reflected in your population. If you see a big disparity from what you're getting from your population from the package insert, you have to ask the question, well, is my population functionally different than the population where the reference interval was made? For example, the package insert reference interval for insulin in our site in British Columbia was a relatively thin and healthy population, was producing results exactly half of what was being produced from a reference interval study in the United States, but it was matching what was produced in reference interval studies in Asia, because insulin is so heavily affected by BMI, right? So this makes sense. So this is a great idea, what has been suggested in the question.
So last question for Dr. Daniel. Regarding the refined R method that you explained, is the software available for commercial use? We can use it in our labs?
Yes, so because that's open source software. So the R programming language is free and open source. You can download that for free, and then you can install the refiner package for free. So I'm all about free software, if people know me, because I think, you receive freely, you should give freely. And so, yeah, I'm only using open source software here.
Thank you so much. Our last question is for Dr. Devaki. What are the first essential steps to introducing AI in the lab, and is it our job or higher management rules to bring it?
As I said, we have to work with the management, work with the clinicians, and we should definitely be involved in the project, which I showed you, the Google DeepMind project. We were part of the project so that we knew what we were inputting into the data and the responsibilities as well, what we take. Because we are going to face all these AKI, alerts were going to the clinicians, and we were phoning results. So we should definitely be involved. Often what happens is the chemists are not involved. The clinician goes to the management, the IT, and they set up something, and we are involved later. So I think my advice would be that anything to do with AI, as 70% of the health record is contributed by the diagnostics, pathologists should be part of that group.
Thank you so much.